Hi everybody. If we can just start making our way back to our seats, we'll start the afternoon session. Hopefully we're all suitably refreshed, caffeinated, and maybe even had a spot of fresh air out in the beautiful Wellington waterfront. Our next speaker is Catherine Leaf, and she's the National Director of the Needle Exchange Program, and I think it's great that she's here and involved in, obviously. I mean, this is an area that she wants to be involved in and is working with a number of agencies and groups around the country to really get things moving. So Catherine, her background is she's on the board of the directors of the International Drug Policy Consortium and a member of the Mental Health and Addiction SLA? Service Level Alliance. It's the TLA. For the South Island DHB Alliance. Catherine was more than 20 years' experience working in drug and alcohol services at a national level in UK and New Zealand, as well as at the international level working for UNODOC. She was involved in some of the early UK harm reduction services in community and prison settings, and she's developed drug policy and drug strategy and has taught various courses and provided a wide range of training services in the UK, New Zealand, Eastern Europe, Central Asia and Southern Africa. So I think New Zealand is lucky to have her, and I think she's adding a great deal to the Hep C conversation. So I look forward to hearing your thoughts, Catherine.
Tēnā koutou, tēnā koutou, tēnā koutou katoa. Thank you very much for that introduction. Biographies are always slightly a little bit embarrassing, so but anyway, someone must have written that, so I guess it might be true. Okay, so I guess I've got the graveyard slot, 1 o'clock on a Friday afternoon. Doesn't get much better than that, does it? Oh, that's not working. This is working. So I promised no PowerPoints, and then I'd change my mind and decide, is it working? You got it? Slight technical, we are working. I thought for a minute I was going to have to pretend I was on the rugby pitch. Okay, throw my voice, would have done the recording in a little bit. So, yeah, thank you very much to the Hepatitis Foundation for inviting me to speak, and I want to acknowledge colleagues in the room from the Needle Exchange, Jenny and Barb, and also colleagues from across the world of hepatitis who work with us in the Needle Exchange. Now, I can't promise that I'm going to stay to script. I can't promise that I'm actually going to talk about what's actually in the conference programme, but that's okay. We'll say that's the English side of me. Okay, so, or I can blame it on the jet lag. But so I've been asked to talk about the role of needle exchange in eliminating hepatitis C, and it's I've took a fairly broad interpretation, a little bit of a licence with that title. So the New Zealand Needle Exchange Program, just to give you a little bit of a headline on a couple of points. So we are, in New Zealand, the world first. We were the first country in the world to introduce a state-sponsored, nationwide needle exchange program. I think that's something we should be tremendously proud of. We're one of New Zealand's most successful public health programs. And why do I say that? Because internationally, amongst people who inject drugs, 13% are HIV positive. In New Zealand, that figure is 0.2%, and that is entirely due to the early introduction of needle exchange. So that is why we are one of New Zealand's most successful public health programs. And I also want to acknowledge my colleagues from the ministry here, because of course the ministry has also played a significant part in that success and ongoing success of the needle exchange. This year, we're in our 30th anniversary year. So on the 12th of December 1987, the legislation was passed that brought needle exchange and permitted needle exchange in law. And this year we're celebrating our 30th anniversary. Now, some of you will have picked up the slightly Pommy accent. I have a bit of an identity crisis. Back home, here, everybody thinks I sound like a Pom, and when I go to the UK, they all think I sound like a Kiwi. But my family's from the west coast I've got family on the west coast of the South Island and grew up in England, so that'll kind of explain that a little bit. But one of the reasons I say that is because when I was living and working in the UK still, we very much were looking to New Zealand and Australia. New Zealand and Australia have led the way in peer-based, peer-led needle syringe programs. And that's one of the defining features of this part of the world and has since been replicated elsewhere. So what does peer-based and peer-led mean? Well, peer-based means that the majority of staff working in needle exchange are themselves former injecting drug users or within the world of injecting drug use. And it also means that that runs right through from the service front level through to the organisation and its board. And that's one of the key things about how we work. In this talk, I'm going to try, but don't promise, I'll roughly try and speak around 3 different areas. What's needle exchange's role in the elimination of hepatitis C? Well, I'm going to touch on advocacy. I'm going to talk a little bit about representing our community, and I'll also talk about the kind of services we're providing and providing in partnership. So first of all, a little bit about some of the advocacy we're involved in. But before that, a little bit more context setting. Because needle exchange is a harm reduction service. Now, people like me use terms like harm reduction all the while, but what actually is harm reduction may or may not be familiar to some of you. I think one of the simplest ways of understanding harm reduction is that it's about safety first. There's a saying, there is no recovery in a graveyard. If we can't keep people alive, they will never, ever be able to make changes to their drug use. The important thing, though, also to recognise when I say that is that not everybody who uses drugs will ever need to stop using drugs. Not everybody who uses drugs becomes a dependent user. The majority of drug users are recreational users for whom their drug use doesn't create a problem in their life. And it's often those who are most socially and economically marginalised in our society who suffer the greatest burden as a result of their drug use often. But safety first is about also building a better quality of life for people who use drugs. In reality, often what happens is it's the spiral of drug use and the other things that affect our lives that means we end up in perhaps crisis situations. If you are an accountant who's using drugs and you can afford to pay your dealer for your cocaine, and if you need a little bit of psychotherapy or therapeutic support and you can afford to pay to see a counsellor and you don't have to wait on a waiting list when you've got a problem, you can just rock up. And maybe actually perhaps you're able to manage your drug use in a way very different from somebody living in a marginalised community, socially excluded and economically excluded. So harm reduction often is part of what actually stops drug problems actually becoming worse and creating greater problems for people. If people actually have accurate information and knowledge and support about their drug use, maybe the dependency never actually really develops. So harm reduction is the absolute opposite on the war on drugs, and I'm going to talk a little bit about that in a moment. Harm reduction is importantly about meeting people where they are at, however they see their drug use and however they understand it. It's about putting our own values and assumptions and prejudices aside and just taking people where they are at and at face value. It's about empathy and it's about understanding. So when you get to talk at meetings like this, you get these wonderful little soapbox moments that anybody who knows me or has heard me speak before will know that I never miss an opportunity to take those moments. So part of harm reduction is about needle and syringe programs. It's about opioid substitution therapy. It's about methadone medicated assisted treatment. That flight I've just took wasn't that far away. It's about things like OST. It's about needle exchange. It's about things like drug checking services. It's about things like supervised consumption rooms, all these things you may have heard about. But actually an important part of harm reduction is also about drug law reform. Because just want to speak a little bit about drug law reform, and I've just come back from a meeting. I have the privilege to sit on the board of the International Drug Policy Consortium, which is an umbrella body that works with the UN and WHO in representing about 250 NGOs internationally in the world of drug policy reform. And why do I mention that? I actually want to spend a few moments now to talk to you about this as health professionals, but also as citizens of this country and of the world. Because part of harm reduction is about advocacy, about the context in which we work. And the laws and treaties and international agreements that govern drug law actually affect how you work as health professionals. We have been waging a war on drugs internationally since the 1960s. Has it worked? Drugs are cheaper than they've ever been. Drugs are more available than they've ever been. Drugs are more affordable than they've ever been, and more people are using drugs. There's a campaign at the moment you may not know about, but over the last 2 years, the International Harm Reduction Network has had a campaign asking for 10% of the money spent on enforcement to be spent on harm reduction. The vast majority of money spent on drugs is spent on enforcement and is spent on prosecuting people and stopping drugs getting into our countries. A very, very small proportion is spent on treatment and assistance, on HIV or hepatitis C, and an even smaller proportion of that pot of money is actually spent on services like needle exchange. And yet the war on drugs is a failed policy. We know it's a failed policy. In the 1960s, there's a number of international treaties that govern how governments are supposed to implement their drug policy. And we've now got a number of countries which are arguably breaching those policies, legalising cannabis, etc. Why are they doing that? Because the war on drugs, to coin the phrase, is causing more deaths than drug use itself. We have rates of murder, violence in the South Americas that are unprecedented. I've just been in Bangkok for the meeting, and in that part of the world, thousands of people have been killed as a result of the regime in the Philippines' war on drugs and trying to eliminate drug use by killing drug users, quite simply. If we think about cancer, we don't try to cure cancer by bombing everybody who's got cancer. Effectively, that's the kind of approach that has been adopted. So the war on drugs is actually a war on people who use drugs. People are needlessly being sent to prison because of drug use, and their drug use is what is finding a lot of people in prison. So if you're socially and economically marginalised, you're committing crimes to pay for your drug use, you're finding yourself in prison. There was a study a couple of years ago that showed that in New Zealand prisons, I think it was 90% of people in prison had either a mental health or a drug use issue. So that's telling us something. So we really need to think about that, because that is the context in which we work. And it's also the context in which people who use drugs live. Because society gives us various messages off the back of all of this. And if we actually change our world, or if we change our world, that's an interesting phrase, if we could change the world, if we could change our drug laws, which Portugal did back in 2004, the sun didn't fall out of the sky. All of a sudden, people weren't going to Portugal for drug-using holidays. In actual fact, incarceration of people who have drug problems in prison has fallen. There are more people in Portugal in treatment. There's a reduced HIV and hepatitis C infection rate in Portugal. So what I'm saying is there is hope. And I'm proud to say that New Zealand is at the forefront of some of this work. We have a progressive response from both Peter Dunn when he was the Minister of Drugs, and the current government is continuing some of that, trying to be more progressive, think differently about the problems. Because the reality is all societies, all civilizations throughout history have used drugs. And really, it's only because of a social and a political construction that some drugs have been made illegal and some drugs are still legal. So what's the substance that causes the most harm in society in New Zealand?
Alcohol.
Alcohol. Legal. Okay? So that's, if you like, the slightly more political element of the talk, but it's something I think really important for us to think about, because it does set the context of how we all operate, of how systems and processes operate in our country. So another part of advocacy that we have in the needle exchange is to talk about is to talk about our community. And often when we talk about drug use, the words I hear and the phrases I hear, we often talk about those people. Yep, them. And I'm very conscious in my role at the Needle Exchange, and when I'm speaking to you today like I am, I'm speaking on behalf of our community. And our community is a community of people who use and inject drugs. And we can all make assumptions. We can make assumptions that in this room today, that nobody in the audience here is a drug user. Because drug users are them, they're others. They're not us, they're not me. But it would be highly unlikely and very, very surprising if there aren't people in this room today who use drugs. You know, and in a peer-led, peer-based organisation, I'm not employed for what I've done in the past, but I'm employed for the skills I've developed over the years. And listening to me, and sometimes people can make all sorts of assumptions. You perhaps think, oh, you know, clearly educated, you know, a certain way that you dress. People will have made all sorts of assumptions about me. And some of those assumptions might be right and some might be wrong. But I'm proud to lead a peer-led, peer-based organisation. You know, I'm someone who's used drugs, used lots of drugs, and used them in all the different ways that you can use drugs. And I think it's important sometimes to share that because it's about breaking down perception. Some of you will also know I originally trained as a lawyer. So don't tell me that lawyers don't use drugs, because believe me, the best supply I ever had was when I worked in the City of London. And in my experience, the medical profession has quite a good supply of drugs and quite a few drug users amongst it. But why do I mention this? Because I think if we're going to successfully eliminate hepatitis C, we've got to think about our attitudes and beliefs and perceptions. And we can't assume, because we're all in healthcare and choosing to work around hepatitis C, that we've actually got our heads around stigma and discrimination. Because you live and work in a society that has perpetuated the war on drugs. It's the reason I've kind of first started talking about it. And we're encouraged to think about the them and us society. So actually what I want you to think about is that it's not those people over there. Because if there's not people in this room who themselves have had a problem, there'll be people in your whānau that have. It's actually our problem, and it's actually about all of us. And the less we can use words like them and us, and less we can talk about working with drug users and just talk about providing services in the community, then I think the better it will be. Because stigma and discrimination is a big issue. It's a huge, huge barrier to our community accessing health services. And stigma and discrimination shows itself in lots of different ways. And I know that research has jargon. I know that every profession has jargon. But please try and see us as people. We're not PWID. It's just a label. We're people. And we don't, you know, when we talk about, we're just doing a piece of work in the Needle Exchange now around language in our communications team. We don't want to talk about having a clean needle. We want to talk about using a new needle, because clean implies, what's the opposite of clean? It's dirty. So we really do need to think about language and behaviour and those little things that we do and say that it can actually kind of, it's almost our unconscious bias. And I think one of the things to say is none of us are perfect, and it's a learning curve. And, you know, we just need to be open to increasing our awareness so that we address our own stigma, our own attitudes and beliefs that can fuel the stigma. Because when our life is different to those that we're working with, it's in the gap between our own experience and others' experience that stigma lies. Okay? So we can't all know what it's like. I mean, I was using back in the UK, and believe you me, the drug world in the UK is very different to the drug world in New Zealand. I don't know what it's like here. But actually what I can do is try to understand and learn about it, I guess that's what I'm saying. So it's in that gap between what my own experience is and the experience of another person that stigma grows. So hepatitis C in our community, we bear the burden. People who inject drugs in New Zealand and internationally indeed bear the burden of hepatitis C. We have in the Needle Exchange a study, it's it's quite a few years old now, but suggests that kind of national prevalence of hepatitis C is in the region of 58% amongst people who inject drugs. But that can vary from as low as 50% to, on the west coast of South Island and South Canterbury, 84%. That's a huge prevalence rate. Typically, as people who inject drugs and use drugs, we don't access mainstream services. I'm sorry, as nice as you are, we just don't trust you. We don't, you know, people, we distrust mainstream health services because we're pretty convinced you're going to try and get us to stop using. We're not going to tell you about our drug use. Why not? Because it's actually illegal. So we're back to the war on drugs. It's very difficult for me to tell you something about something that I know that I'm told I shouldn't be doing. We find it difficult to engage in services because often the services don't actually reflect and work with our needs. You know, we might, you know, sometimes we just need appointments made at a time that we're more likely to attend. We might need that gentle reminder so that we actually turn up to a service. It's not that we don't care or we're not motivated. We just lead pretty chaotic lives, and we genuinely do forget. And for those of you who've not used drugs, you know, sometimes our short-term memory can be a little bit, and sometimes our long-term memory can be a little bit. It's not the same for every drug user. It depends what we're using, how long we've used, blah, blah, blah. And funnily enough, as nice as you are to us and as important as getting that test actually is, if we've got to get something done in order to sort the dealer out, that's probably going to be our priority. Okay? So we generally don't access or maintain engagement with mainstream health services. We're also not actually, we found in the needle exchange program that people actually aren't still that aware about hepatitis C. There was a big hoo-ha around HIV, but there's still, surprisingly, we may all think, quite a lot of ignorance around hepatitis C. There's a huge amount of ignorance around the new treatments. A lot of our community still think it's interferon, and interferon nobody likes, we know that. Now this varies across the country. There'll be pockets where actually there's a really good knowledge, but there are some areas where we don't know about it. The other thing about Hep C in our community that you need to be aware of is it's in the future. If you use drugs, typically we don't tend to think long term. Well, that's a big surprise, isn't it? We tend to be focused very much on immediate gratification. We have difficulty thinking about the medium term. So the longer term, what do you mean I might die in 20 years? Oh, it's 20 years, I'd be lucky if I even see that, you know? Or we don't think long term. Our priorities may not be the same as what the average Joe Bloggs living a so-called normal straight life, his priorities are. So we don't think about it, okay? It should be all right. There's also there's quite a lot of fear in the community, I think. So you may just think it's a blood test. For us, it's a vein. Why on earth would I want to give you a vein for a blood test when I want that vein? So our veins are pretty precious. If you've been injecting drugs for a long time, you don't have many, typically. And tell you what, we're probably better at taking the blood than most of you as well. So, so our veins are really precious. I think we need to understand that. We're just picking up also that for some people, we as so-called normal straight people may think, well, if you've got hepatitis C, of course you want to get better. Why wouldn't you? Well, that might mean I'm off the sickness benefit. And that's actually, we're finding out now, becoming quite a barrier to our community wanting to access treatment. Might be totally counterintuitive to you, but for our community, that's it. If the hepatitis C, they're on the sick benefit. If they get well, oh my God, I might have to find a job. And the current work and income's way of making you find work isn't something that particularly people are welcoming. We're also fearing judgment. We don't know how you're going to treat us. You know, as I walk into that clinic, into that hospital, that's the drug user, you know, and sometimes people's reaction to us is just almost kind of so unconscious and intuitive. You know, don't make eye contact with them, you know, that, you know, kind of giving them a bit more space as they're walking through the corridors. Those kind of things, you know, you get to notice when you're not being really accepted. And I guess people are kind of also worried that if they engage in hepatitis C, you're then going to force them to try and change their drug use. Okay? And so it's like, well, okay, so starting there, what next? So I think we just need, we need to be very much aware. Our job is to say to you as a group of health professionals, these are some of the things that our community think about. So needle exchange services, what do we do? Oops. No, I've gone on to the next slide. So part of the needle exchange's role, I think, is to speak out, is to make it possible for our community to access hepatitis C testing and treatment in a way that reduces barriers to engagement. I think, we know that our community will go where they feel safe. And one of the best things that you can do is take your services to where people feel safe. It's kind of funny, isn't it, really? For so many things, we expect people to turn up. But people don't, generally speaking, turn up. There's lots of other reasons, there's lots of other things to do other than to turn up at an appointment. But if you can take the service to where people are, where they're at, and where they feel safe, you will get a better engagement. And it will take you time to earn their trust. Okay? I think one of the important points to also highlight when we're talking about hepatitis C and talking about our community is please don't stop treatment because we're still using drugs. One of the things that as drug users, we're really good at is taking drugs. And there is no international study that I'm aware of that has yet suggested that people still active in their drug use cannot be cured of hepatitis C. There's every reason to still continue to treat them because adherence rates are still very high. But we are getting anecdotal information that in parts of New Zealand that is not the case, that people are being denied treatment because they are still active users. That flies in the face of all the evidence, and as a needle exchange program, we will continue to speak out and speak up against that. Because the important thing is to coin a phrase from some Canadian activists, while you're all busy talking, we're all dying. Because this is about life and death for our community. If we don't get this right, we have the opportunity to eliminate hepatitis C. And if we don't get this right, it's members of our community that will bear the burden. And it will be people who have injected drugs that will be the people who die. So we need to get this right. And I know there's been some conversations around the pangenotype treatment because I think that's a really important development that needs to come as well, particularly for the South Island. So the needle exchange services, I've talked a little bit about them, but basically 22 services, 190 pharmacists, and we distribute over 3.3 million items a year. We have a number of services that actually have a clinic attached to them, done in different ways. The three main clinics are in Dunedin, Christchurch and Auckland, where there are permanent services, effectively, of differing degrees of intensity. And then there are other services throughout the country where we might have a monthly clinic, we might have a weekly clinic, we might have a fortnightly clinic or a bi-weekly clinic. And they're all very welcome. And I think we need more. Because I've already said to you that drug users, generally speaking, chaotic. So they ain't going to remember to turn up the first Thursday of every month. We've just done a pilot in the needle exchange as well around rapid testing, showing that actual fact, the study basically showed that we can use rapid tests in a needle exchange setting, that we will access large numbers of people who inject drugs in that setting, and that they will get involved in the testing, and that we can then onward refer them to treatment. And that testing was also done by peers. So if we really want to increase access to hepatitis C services, the involvement of peers is critical, because you guys can't be there all the time. And I can't guarantee you that 20 people are going to turn up the first Thursday once a month, the first Thursday of a month to come and see you. But if we can have peers involved, we can actually do more. So how can the needle exchange contribute to Hep C elimination? We're really open to having clinics in our services. We'd like to see more clinics in our services. Because we're peer-based, peer-led, we have a credibility within the community. The community will come to our services. And if you like, we can be the broker. We can provide you with a bridge and a link. Because if we've let you into the service, then you're probably okay. Still take them time to build up some trust with you, but that's a really important point. We also can build awareness and education in our community, and I'll talk a little bit about that in a few moments. And we're also available to provide awareness and education to health professionals and to talk about what it means to inject drugs, talk about the lives of our community, and to address stigma and discrimination. Little kind of side story, my last job, if you like, in a service before I got caught up in sitting on computers and writing business plans and strategic documents, I ran a 120-bed wing of a prison in the UK, which was a high-security prison, and big old Victorian jail. And this is going back longer than I care to remember, 15 years, 20 years, 15 years. And I had these 2 drug and alcohol counsellors, and I had a team of 10 prison officers. And it's one of those hardcore prisons where they still wore the hat and wore their uniforms, and they thought drug users were scumbags, those junkies. And I thought to myself, how on earth am I going to make this work? So we did a half-day training. We did some training, and I took half a day, and I took these officers through how you make a fix and how you prepare your drugs for injection and what you do when you're injecting. So I got permission, took in all the needles, I had the spoons, had little packets of coffee powder, because of course in the UK we're talking about heroin. It was all wrapped up like a wrap would if you'd scored on the street, and it took them 3 hours to make this fix. And they were trying to juggle the equipment and hold the lighter with the spoon, and anyway. And at the end of the training, I said to them, so that's what's just took you 2.5 hours, takes your average drug user a minute while they're walking down the equivalent of Lambton Quay. And they were like, you could see their faces go, because it was, wow, they've actually got some skills, you know? So sometimes injecting drug use is not perhaps a world, even though many of us will use drugs in this room. I won't ask you to put your hand up, don't worry. Many of us may not know about injecting drug use. It's a bit of a myth and a bit of a mystery. So sometimes things like that can actually let you in and understand the world. So moving forwards, what could be and what is going, what are some of the things that we're doing, and what could be the role of a needle exchange in Hep C elimination? The rapid testing pilot has shown that peer testing works. We've already got home HIV testing kits. It's not going to be long till we've got home Hep C testing kits. You know, oh yeah, we might share if you've got to prove to me that you. I mean, God forbid that stuff happens. But we know that peer workers can do rapid testing. So let's use peers as providing rapid testing and needle exchanges. But if we're going to do that, we need to make sure we've got good treatment pathways into services. And that's absolutely essential, because otherwise we're going to lose the value of the rapid testing. I think one of the things the Australians have done, and my ministry colleagues know I've mentioned this, and I'll probably be mentioning it again, we need to look at, and indeed we're exploring with the ministry, what's the possibilities around peer hepatitis C support for peer workers who inject drugs, who've had hepatitis C, to be just a support worker, an advocate, help you navigate it's great in the big cities, we can have these nice clinics, but if you're in Greymouth, we can't have a needle exchange in Greymouth. Probably need one, but it's not a big enough population. So who's going to go with me along to my appointments? Someone could remind me of my appointments, pick me up, take me along, sit with me, kind of say to them, don't worry, even though they're looking at us really funny because they know we're the junkies. That kind of support would enhance treatment engagement. And I think one of the things we've also been talking about, again with the ministry, is about a wellness perspective. This shouldn't just be about hepatitis C. We probably don't have to worry too much about HIV in New Zealand, although we've got to keep our eye on that because we've had a few more positive results over the last few years. But actually, what about Hep B? What about other health issues? When I was working in a needle exchange in London in the 1990s, you'd talk to somebody, engage them, they might disappear, they come back, and you build that relationship, and you'd build the trust and the credibility to be able to say to the person, oh, your vein, can we talk about this? What have you been doing? Can I get the nurse next door to address it? And while you're there, could we take your blood pressure? All those kind of health services. Needle exchange is a place where actually we can improve people who use drugs and inject drugs' health. Probably won't surprise you after you've sat listening to me for about half an hour now to say that, I'm a strong believer that we should be able to provide services for our community. Sure, we're happy to do it in partnership, but actually I would also advocate at the moment things are pretty much being done to us. And I'd like to see things done buyers for us. We actually, we have got pilots that we're running where we're providing the services, and we're bringing people in for a project that's actually done by us in partnership with others. And I think that's a really important way. It's about us taking some control of our destiny. For example, HIV in New Zealand is mainly an issue for men who have sex with men. Nobody would suggest that the MSM community shouldn't be at the forefront of the response to HIV. We wouldn't expect that it would be the straight community that would take it over. So it's the same kind of parallel. And one of the big things that needs to happen moving forward is if we're going to eliminate hepatitis C, and this won't come as a surprise to a number of people in this room, is we have to upscale distribution. Because people will continue to use drugs, they'll get treated. If we're not upscaling distribution of needle exchange, then we risk reinfection. And that's common internationally. I'm not alone in calling for that. So how are we going to speak to our community? Because I've got 2 slides and I'll shut up. But we have a role in educating our community, and some of you again will be aware we're working with the Hepatitis Foundation, with the Health Promotion Agency, and we're running a small awareness campaign within our own community. And our campaign is actually only about people who currently use our services. We're not general population level, we just want to reach the people that we work with. And I've been working with some of our service users, and we have to be careful when we do campaigns, because sometimes we can use language that we may think makes sense, or we may think is relevant to people. Hepatitis C is curable, come and get your test. That kind of makes, it's not a very good phrase maybe, but it perhaps makes sense to us. I was talking to our service user group about what kind of phrase they thought would encourage people to get tested. And they came up with, don't be a dick, get a prick. Now, that may not be the sort of thing we would come up with. I suspect it isn't. We'd probably err more towards hepatitis C can be cured, get tested. That doesn't speak to them, but don't be a dick, get a prick does. So we will do things like that to raise awareness in our campaigns. Raise awareness in our community through our campaigns. And sometimes some very simple things. A lot of our peers, a lot of our clients don't have a lot of money. We're going to be flooding the needle exchanges with a few T-shirts, and that's a way of getting the message out. Don't be a dick, get a prick. It's going to be great walking around Greymouth with that T-shirt on. Almost as good as the T-shirt I've got that says nice people that use drugs. That kind of causes a few bits. We're also going to use digital platforms. We're obviously going to develop a social media focus around it. We actually currently have a website that's aimed at people who inject drugs around hepatitis C. We're redeveloping that. And we're doing some peer stories. So people who inject drugs, who've had hepatitis C and have been treated, and we're doing a peer stories booklet, and that will also be done as a video. And they say, pushed around our community. Funny, for some strange reason, people will trust information that comes from us. Not strange at all. Okay, final slide. Probably used up all my time, but keys to success. I guess just trying to pull together some of the things that we've talked about. Eliminating hepatitis C, we have to involve people who use drugs and people who inject drugs. We need to be mindful, I think, of the context in which we work. And we need to take up that challenge as citizens and professionals. So I encourage you all to read, to get involved in, to be aware of what's happening nationally and internationally. It is important because it underpins some of those key messages. It is a complex problem and challenge. Drug use itself is complex. The reasons people use drugs are many. The solutions to the drugs issue, if you like, at the moment we have a lot of methamphetamine use in New Zealand. We can have a whole discussion about why that is. We're seeing a lot of people now injecting meth. But we also have a huge moral panic around methamphetamine. I'm not saying it's a good drug. No drug is good, if you like. All drugs have risks and cause problems. But it's, we also have, we had moral panic over synthetics. And now look what's happened. We've had 20 people die last year from synthetics. Was there a public outcry? No. If, I think my colleague at the Drug Foundation dared to kind of use the quote that if 20 kids suddenly died at a Remiora school, there'd be a public outcry. Was there a public outcry when 20 people died from synthetics? Not really. So it is complex, but we do need a multi-pronged approach. We need you, and you need us. is what I'm suggesting. So partnership is the key to access some of these groups. And final point, because I can't resist saying it, and some of you here won't be surprised to hear me say it, we need to increase our investment in harm reduction. Because if we just give people lots of drugs, as in the treatments, without increasing in harm reduction, then we won't eliminate hepatitis C. So thank you very much for your time. I don't know if I've overran or underran.
Catherine, it was a fabulous talk, and I'm sure all of us can take something away from that, so thank you very much for your thoughts. We do have a couple of minutes for questions, so if you want to fire a microphone down to that lady at the back.
Hi, I'm Cheryl. I'm the Program Coordinator for Hep C for the Central Region. I've emailed you. Yep. I was just wondering, have you got a process in place where you are training your peer group to do point-of-care finger prick testing?
Yes, absolutely. So we're just in the process at the moment of putting together a program. So in order, we need to have ongoing discussions with our ministry colleagues about the needle exchange doing peer testing, but they are supportive in general terms. We will have a quality assurance process within the needle exchange, which says that the local exchange needs to have developed a treatment pathway, needs to have various things in place. And then, yes, we do actually have a training course that will train peers to do that. And part of that training, it's a range of different components as part of the test, part of the training, including things like pre and post test support. I think sometimes there can be concern that people aren't skilled enough or won't be able to handle people's emotions. But you know, back in the 90s, I was doing pre and post HIV testing. And not all peer workers will want to do this. I mean, I think that's the other thing. It needs to be clear about what I'm saying. I'm not saying that every worker in a needle exchange will be doing peer testing. Some will, some won't, but yeah, training's an important part of that, and there's a number of components to it, including explaining what the test is, explaining about window periods, explaining the need to come back, explaining about treatment, and kind of what your test result means. Because, of course, I mean, it's not, you know, I remember, I was doing a lot of HIV counselling and work back in the 90s, and, you know, just because you got a negative, one of the biggest messages that we were trying to give people was just because you haven't got it yet doesn't mean to say you won't get it. So, you know, that kind of harm reduction advice as well.
Catherine, fantastic talk, as expected. Do you think there's going to be a possibility for test and treat in needle exchanges? And how your peer work is going to engage people long enough to wait for, because there are some point of care tests where you can test people within an hour you have a result.
Yep.
And then you send them out with a prescription. Do you think we'll ever get to that stage? Perhaps only in the major centres, because you've pointed out the issues with West Coast, etc. And do you think it's by turning a hepatitis C intervention into a healthy liver intervention or healthy vein?
I think Ed, that has to be part of the solution, is that we actually have to talk about holistic well-being and health. I think we also have to recognise that for some people, going into an exchange is a quick in and out. You're not going to get them. They might be in there for less than a minute, and I've managed drug and alcohol services for more years than I care to remember now. And I used to get really disappointed. It's a story I often tell. I was a general manager of a national alcohol and drug service in the UK, and I used to get really disappointed when I was doing induction staff training, because what I would basically hear from the staff is, oh, you know, I'll become a really experienced, I'm the top of the range, the best drug and alcohol workers are in rehab. And, you know, we're doing that real work, that therapy. And I used to get really disillusioned when I heard that, because, to be honest, I've worked in needle exchanges, I've worked in the King's Cross area of London, I've worked in prisons, I've worked in therapeutic communities. The easiest job I ever had was in a therapeutic community, because I knew who was in there, we'd done assessments, we worked with them every day, and, yes, being a therapist is skilled, but actually, you know, some of the hardest work is that frontline service. And the reason I kind of mention that little anecdote is because I think sometimes we don't appreciate the real skill there is in a service like a needle exchange of building that trust, engagement and rapport. And it may take us 3 months to even get you to say hello to us, or but there's a skill in doing that. So we have to build the credibility and the trust so that we can then have permission to suggest other things. And I think, there's a range of issues, from practical issues like some of our exchanges would be more suited to keeping somebody in the service for an hour than others, but I think if we can overcome some of those practicalities, then we will be able to certainly do some of those things. But I think what we need to do is to set things up that are actually going to work rather than setting people up to fail. And the best way of doing things is to run a few pilots, see what works, take the learnings, and then move on from that.
Catherine, it's Jo from the Midlands. We've had such a pleasure getting to know the peer and the needle exchange within the Midland region. And in Mount Maunganui, also lucky just the time, like we go in and they decide whether they want to work with us or not. And it just takes that time to build up the relationship, which is pretty cool. But we're actually aiming for a gold standard within the needle exchange of a one-stop shop, realising that time and veins and everything are very important. And we've got Nicola working out of the Mount Clinic with the oversight of Tony, the GP. And we are doing, and now we're introducing point of care testing and our clinical pathway to align with the clients that we're working with. And we're getting some lovely, lovely stories now, so we can get a finger prick, follow-up bloods by these nurses who are expert in blood taking, a fibre scan, and manage the treatment within the exchange to make them feel safe. And we're actually rolling that throughout the Midland region now. We've got our point of care clinical pathway. We've got a gold standard, then we've got not every situation is gold standard, so working through other ways to give results and follow-up blood work, etc., and care. And we're just considering looking at a support to service or a support role for some of the things that you mentioned about how do you pick up your meds and do you need help with transport and someone to keep an eye that you're taking your medication. So,
yeah, I think those things are really, really important. I mean, I guess one of the things I'm also really mindful of is being a West Coaster is, rural New Zealand is the size of New Zealand's third largest city. So how on earth, and when you look at prevalence rates in places like the West Coast and South Canterbury, how are we going to engage and help access? And one of the things we're doing in the needle exchange at the moment as a pilot, or will be doing, is an online exchange. So what does digital platforms enable us to do in terms of accessing places where we're not currently accessing people? Because that's one of my biggest concerns. We can get people to Christchurch, we can get people into Auckland. If I'm near New Plymouth, I can get into New Plymouth. But what if I'm in the rural what-whats? And probably I'm also sharing. So what does that mean? So
we might round that up. Catherine, that was an excellent talk. Thank you very, very much. Our next speaker is Darren Quirk from the Health Promotions Agency, and we're pleased to have him with us. So Darren works in the marketing team here at the Health Promotion Agency. It's a Crown entity whose vision is inspiring New Zealanders to live healthier lives. He's worked in marketing for over 20 years for NGOs, government and commercial organisations, including Outward Bound, Te Tuma Pairoa, the Volunteer Centre, Kiwi Bank and Mobile Oil. Big oil. Work for the dark side. Darren lives in Porirua and has a busy life with his partner and 4 children. Darren, thank you very much for coming.
All right. When you've had a stretch, I ask you to get back to your seats and we'll get cracking, because I realise you've got there's flights to take and that this afternoon as well. So hopefully everyone's enjoying the Wellington City. We've put a bit of good weather for you, for those that are out of town, and hopefully you had an opportunity to check out the city a little bit. I'm from the Health Promotion Agency, and the Health Promotion Agency has been asked by the Hepatitis Foundation in partnership with the Ministry of Health to assist with the with a Hep C campaign as part of the system that is working in the area of Hep C harm prevention and minimisation of problems with. So we're part of that system. So seeking for us to make a contribution. For people that don't know what the Health Promotion Agency is, it's a Crown entity. There's 100 people, so it's not that big. Was the Alcohol Liquor Advisory Council, then combined with the Health Sponsorship Council. So in some ways it does a whole lot of government marketing, if you like. And some of the work that we do involves research, so that's the informed part. So we do a lot of research that we share with the sector. The enable part is that we provide resources to people that are working in the community, and the promote part is when we're doing campaigns ourselves. And some of the campaigns you're probably familiar with, starting from the top right-hand corner, the John Kerwin ads around depression, the lowdown for younger audience in the mental health space, Say Yeah Nah is alcohol work, stuff in the tobacco space, sun safety, gambling harm reduction, nutrition, immunisation. So I was interested in hearing that Hep B stuff this morning. Did some work in RF, and so that's some of the work that we do. What I was going to talk to you today is about a campaign that we're doing for Hep C to support everyone's work that's in the room, and it's a real privilege to work in a new area, so thank you for inviting us into your world, and we've been in touch with a few people along the way that have been really, really helpful, so thank you. I'm going to talk about a case study of some of the other work that we've done to show an example of the process of going through a campaign, and I think the abstract that we had there was getting past the jargon. This isn't so much to get past the jargon, it's as much to show that quite a lot of thought goes into a campaign, and for the HEP campaign that we've got, I think we've gone through a pretty solid process, and we're hoping for a really good outcome and to contribute to your objectives of getting more people tested. So I'm going to show, this is in the oral health space. This is an ad that we put out last year.
Hello there. You haven't been brushing your little one's baby teeth, have you? They can mess up their adult teeth, eh? Pretty easy to avoid, really. Just a little bit of fluoride toothpaste. Open up. Just some gentle brushing, morning and night, to protect their smile. Spit. That wasn't too hard, was it? We're not going to have another little talk, are we? No. Good man. I'm going to go now. Nice. Sleep tight.
So that was a really nice ad that was created about a year and a half ago, and it was that's the end of a whole piece of work. And so when people see advertising, there's a whole lot of thinking and effort that goes into it. And the same way for the Hep C campaign has gone that way as well. So when the issue that's faced with tooth decay, and this is a shocking picture, and I could have put even more ghastly pictures up of kids suffering that they suffer with tooth decay. The fact is 29,000 Kiwi kids have teeth removed every year. Most of them, or many of them, under a general anaesthetic in hospital, so we're bogging up our hospitals with preventable diseases. And yet the reality is less than half Kiwi kids brush twice a day, a preventative measure, and we live in a real sugar prevalent, sugar dense society, so there's lots of risk factors there. So when the ministry approached us 4 years ago in the space of dental decay for under fives, because that's where the problem was, the question is, where do you start if you want better health outcomes? It's really easy to come up with what the problem is, but how do you solve it? So things you need to think about is what interventions work, so that's about looking overseas and what's working in New Zealand. Looking at what's the potential behavioural solutions. So we've got tooth decay, but do we go after reducing sugars? Do we go after toothbrushing? Do we go, there's a whole lot of range of different interventions that you could have. Who should we be targeting? And that's based on, where is the harm felt the most and the risk factors. And what are people currently doing? And what are the behaviours and motivations to change for those people? And what's the sector perspective for people that work on a day-to-day basis, people trying to cause change? So some of those things that we had to work through. And on the oral health space, that was some of the pieces of work that were done to ensure a really robust platform. So we did literature review, looked at all the international research about what works in the space of reducing decay for this age population. We did a whole up and down the country work with stakeholders about what works and what their views was and where we needed to intervene. And we did consumer research, so 1,000 Kiwis, parents and caregivers were asked about their current practice and what their motivations and barriers were. And as a result of that, we were able to get quite a clear sense of the things that we needed to work with and the things that we needed to reduce. And in this case, for oral health, I won't dwell on them too heavily, but the motivators were that the parents were really keen for their kids to look good, have a nice smile, and equally they didn't want them to be the kid that got teased at school because they had ugly teeth or bad breath. And that personal hygiene still was a social norm that came through, was still valued and was considered in the washing regime. So being clean was considered something that people valued, and people didn't want pain for their children. Equally, the barriers were the first couple were knowledge barriers. So there was things that people didn't know. So baby teeth don't matter because people consider that they fall out. So what's the big deal? They're going to come out anyway. I'll kick in toothbrushing or care of my children's teeth when they get real teeth. So there was, and yet there is a causal linkage between the health of baby teeth and the health of oral teeth. So we needed to be able to get that across, and you would have seen that in the ad. And there's also an overstating of child's ability. So often parents are delegating toothbrushing to their kids way earlier than what they need to be. So it's the parent's job, and as you see in the advert, it placed the responsibility a lot more on the parent. Then there's another couple of barriers that are harder to work with, and we didn't choose to work with them in the campaign. Stuff around resistance from children and stuff around parents having busier lives. Those things are hard to change, but what the campaign sought to do was elevate it as a priority in a parent's busy life. And then what we did is develop a few concepts, few alternative ways as a result of that, and then we tested them with focus groups, and this is the same thing that we've done with Hep C. And then as a result of that, we were pretty confident with the different alternative advertising concepts that we were going to use. We got a clear sense of which ones were going to work, and we got a clear sense of which ones weren't going to work. And that gave us the confidence then to launch a campaign. The other side of social marketing is we have got a budget for this campaign. It's not a big budget. It's relatively modest, mid-scale, I'd say, mid to small scale in terms of its amount. But when you spend money in media, you've got a massive amount of different channels to choose to spend your money in, and they all have different attributes. And so how do you choose? And so you've got TV, radio, and online and social, and in this world you've got a proliferation of channels. In the old days it just used to be newspapers, radio and TV were the only channels. Now it's a lot trickier. But the good thing is that most of these channels can be measured. So if you're very clear on your audience, you can typically buy a channel selection that will find your audience. And there's a whole lot of research and survey data and metrics that allow us to make really informed decisions in that space. And here's an example from the oral health campaign. So this was from Nielsen data. So they survey a panel of people with their media consumption, and it showed that TV was going to be an important channel for that campaign, because that right on the left-hand side it shows the 50% of Māori Māori parents and caregivers of children under 5 consume TV 23 plus hours a week. And from the reach that TV gave, we knew that that was going to be an important part of the campaign. The other part of the thing is in terms of what's the strategy. So for oral health, we were really keen that from the research it showed that if we want to influence parents, that we needed to influence them from within their world, and social media was going to be a useful way to do that. So it's about strategy as well. We good for time. Then we look at measuring success. Sometimes it's easy, sometimes it's hard, and it depends on the level of investment you put on success. But usually you can find reach through the campaign metrics that you have. In this case, we reached 70% of the audience through TV alone, and then we measured that, and it was about 88% of the audience saw the adverts. There was an uplift in web traffic. We got 20,000 social media interactions, so that was comments, shares, posts. But the more powerful things were the knowledge shifts that we measured through evaluation. So we spent some money to go back to about 1,000 Kiwi mums and dads and ask them, as a result of seeing the campaign, what's changed. And the exciting thing about this campaign that we saw, 30 of those surveyed, 35% had made a change to the oral health of their children, and that was either brushing more regularly, or in some cases it's buying a toothbrush, or changing toothpaste, or just being present at toothbrushing time, or just reminding things. So it's a range of things. But so some of that sort of shows you some of the process and thinking that goes through in terms of construction of a campaign. Now I'm going to talk about Hep C. We've, for the last, what are we now, July? For a few months now, have been working on a process with the stakeholder group, working very closely with the Hep Foundation and the Ministry of Health, and they have an advisory group, so there's a governance structure there that keeps us honest to make sure that we don't go too left field. But we've gone through a process of discovery to understand what research is out there, what do we know about the issue, what's the role of HPA, how can we contribute. Then we've had to do some work around deciding, because we're never going to get all the information that we need. There's lots of unknowns in this space, and making some calls on target audiences. And then we designed a campaign, which we then tested. And I think some of the people in the room here have probably been involved in the testing. So we tested some of the concepts that we've developed. And then we're pretty much not too far away from being ready to gear up to deliver. So in terms of target audience for the Hep C campaign, lots of discussion was had about where do we place our effort and energy. So if you imagine that circle, these aren't to scale, but that circle was the 50,000 that was talked about today. And so on the right-hand side is the 25,000 people that know that they have Hep C, and they're either in treatment or they're not in treatment. So that could have been one audience. The other audience could have been health professionals, doctors and primary care, because they're an audience, obviously, and we've talked about that today, the role of influencing that audience. And then the green piece could be people that are at risk of having Hep C in the future, and that be a more preventative style campaign. The target audience that we've settled on is the don't know have Hep C, so it's people that don't know that they have Hep C. So it's that 25,000 that we've talked about. Then if we drill a little bit deeper within that, so our campaign is targeting those that are at most at risk of having Hep C, and as Tony said in his presentation this morning about the intravenous drug use risk factor being the most prevalent. It's by far and large the most prevalent risk factor. So that's people that have injected drugs in the past as the target audience for our campaign. We've quite deliberately kept separate the work of people that are currently using, and as Catherine's talked about, their organisations and their communities that they're interacting with, that's the best place for those communications to happen. So ours is a bit more of a public campaign. So we're targeting 45 to 60-year-old Kiwis who have injected drugs in the past, and with a skew to males. That's the sort of the bullseye target audience. That's not to say that our campaign won't spill out and give benefit to some of the other segments, but that's so that give you a context of where we're seeking to aim. And when we look at key campaign messages, we had to work these up really carefully. So we've done this as a process with the Hep Foundation and the Ministry of Health and the advisory group. So some of the things that you'd expect, Hep C is serious, it can lead to liver cancer. There's many ways you can get it, like being tattooed. The most common way of getting Hep C is if you injected drugs, even if you've only done it once. An estimated 50,000 Kiwis have Hep C, and with better and easier treatments, now most people with Hep C can be cured, helping you feel better fast. The call to action, what is it we want people to do? We want people to get tested. How do they do that? They call their doctor, is a simple call to action. And then we'll be sending to a website, which will be a page on the Hepatitis Foundation page. So there's lots of messages in there. If you had to boil them down, you probably squeeze them down. If you've ever injected in the past, you should get tested. And you can see we've wrapped around a number of other messages that expand that messaging set. Some of them are to reduce stigma, and some of them are to round things out and to give the full story. But if you had to boil it down, that would be the nutshell. If we are going to be successful in this campaign, we need to get people that have injected drugs in the past to get tested. That's the raw form of it. So what we did is, once we developed that set of messages and tested it with the governance structure, we worked with 3 advertising agencies who all competed for the work, and they gave us about 9 different ways that we could get this message across, and there's quite an art to that. And from that, we took 4 of those to a testing regime, and we've tested with people, tested these different alternative advertising concepts with people, Hep C patients, people that work on a day-to-day basis with people that have Hep C. And then we were fortunate to manage to find people in our bullseye target audience, people that have injected in the past, and their friends and family as well. So we've tested the concepts with those groups, and as I said, some of the people here in the room were in some of those testing groups, so thank you for participating. And what the testing showed us really was that there was pretty confident that we've got a concept that we're running with that was really well favoured, that people thought resonated well and hit the messages properly. We were testing what we knew and we had to test our assumptions, so really figuring out what we know versus what the public's telling us. And they were telling us that the message set that we had, so all those messages that I had before, were on the money. There weren't many that they were saying, hey, you need to be saying this, you need to be saying that. They were saying, yeah, that hits the mark, you need to be. So that was very positive. And then managing stigma was really important, and we knew that going into this work, and we've known all through that we have to walk carefully the road. And to be honest, that's going to be a tightrope for this piece of work, because we are going into the place where we are saying a message that is trying to tap into an audience group who in the past have done an illegal an activity that currently is illegal. So it's not necessarily an easy space, and Tony talked really well about stigma and the different layers of stigma. So we're really mindful of that. And I think some of the things that we're able to see, some of the tactics in the communications that help reduce stigma came through the testing, as well as some of the work that we've done. Being able to show that people from all walks of life have Hep C, showing that it's widespread, the 50,000 number, showing that there's many ways to get it, not necessarily only through intravenous drug use. That sort of came through in the concept testing, that even though the risk factor is intravenous drug use, giving people an out that isn't just intravenous drug use was important. And you label the person, not the behaviour, and there's no judgmental references to intravenous drug use. So the campaign, the advert that we'll be going with doesn't place any labelling on whether intravenous drug use is good or not. And then from that, we're looking to run a campaign. So 4 concepts were presented. I'm aware some people in this room wouldn't have seen that, but others may have. So this is the concept that we're looking to run with. And I can read you the script, because we're sort of at that stage, we're actually fairly down the track. So if you could imagine, this is a video advertisement. It's a 30-second advertisement. It's called People Like You, but you won't see that term in the advert. I just need to check my specs on. And we open with a 55-year-old guy. His granddaughter hugs him. He turns to the camera and says, this is the grandfather, over 50,000 Kiwis have hepatitis C. Next we say a different person who says, many don't know because the signs can be subtle, like tiredness. Then the next person says, there are many ways to get Hep C, like getting tattooed, but the most common is from sharing needles. Person 4, even if you did it once back in the day, if you've ever injected drugs, you should get tested. Hep C, and then the next person. Hep C can stay undetected for years and cause liver cancer. With better and easier treatment, now most people can be cured. And then the last person, ask your GP for a Hep C test. These aren't the actual people. We'll be casting for people, they're everyday Kiwis, and we'll be getting a range of Kiwis. And from the testing, we're able to get a sense of what personas we needed to have in the casting as well. The reason that this concept was chosen was that it really showed that people from all walks of life can have Hep C, and also it wasn't that it allowed us to tell quite a big story about Hep C, so actually get quite a lot of information across. So it was about awareness, a bit of knowledge, as well as some of the emotional part that we needed to get across. So these, as I say, these visuals aren't exactly what it's going to look like, it's just an indication. And then the last one, my last slide, is in terms of getting the message out. So it's going to be a combination of earned media. So we're going to be looking to do some PR. So we're hoping to get some articles and pieces in different media. So whether that's TV or whether that's in print or whether that's on radio, where we've got people talking about it, real stories about Hep C. We're doing the paid campaign, so that's likely to play out in online TV, so TV on demand, YouTube. There'll be a bit of social media and some radio. And then the extension of the campaign through stakeholder channels, so that's where we'll have posters, and we've got the video, and we've got online banners that you'll be able to share in newsletters or on websites, or the posters putting them up in different places. So that's sort of a bit of a wrap-up of what's planned ahead, and we thank everyone for their input that have helped put it together so far. Did people have any questions?
Could I ask a question? Where you have got the call to action, get tested, call your local GP, would it not also, given what we've been hearing today, with Catherine Lee speaking, and I'm a manager of a needle exchange.
Sorry, just lift the microphone up.
Sorry, I'm a manager of a needle exchange. I would actually like to see potentially something around call your local needle exchange.
Yeah.
Put into there, because we are trying to break down these barriers. We are also trying to hit our population as well, and I feel that that could be prudent. Did you have someone from the needle exchange on this advisory? Because, you know, we're trying to destigmatise, and the harm reductions. I just feel it might be prudent. I don't know what other people think, but that's just my take on it.
Yeah. So for anyone that didn't hear that question, it was about whether the call to action says call your GP, whether that should be expanded to call your GP or needle exchange. I mean, it's there were people from the needle exchange on the advisory in the process of the concept testing and in the advice group. So, and Catherine inputs as well. This campaign, the needle exchange has its own campaign in some ways to their community, where they're able to tailor the messages and the tone and the feel and through the staff, whereas this one is a bit more public and it's a bit more broader. That's not to say that the website address that we have down the bottom doesn't refer to different ways that you can get care for Hep C. That may not necessarily involve calling your GP, but
we've already heard often people don't like to speak to the GP, whereas they might be more comfortable, and if that avenue was there, it's just a thought. And I agree, and everything's valid in this space. That's why that when you put together a campaign, you're blending a whole lot of different conflicting pieces. I think the differentiator for this is we're not targeting current drug users with this campaign. There's people seeking clinics out there that could be accessed as well as the GP. So,
well, I think you could list them under the, if you're giving one website, say the Hepatitis Foundation, we should make sure that on that website it clearly states those options.
Yeah, so what we'll do is we'll take advice from we don't make the decisions, we're an agent, so we work in partnership, so we'll take that offline with the Hep Foundation and the Ministry and the advisory group in terms of that, because I know some of the other places have said, I think Northland in their ads, they say health professional instead of GP.
I think that the fact that your campaign actually talks about one of the main reasons that you can get hepatitis C is through intravenous drugs, that they actually need to be on there.
I think so.
Yeah, I mean, it's again, you're saying one thing and then you're saying, well, they've got their own, but it's all in one, isn't it?
Stigmatising.
It is. Yeah.
Yeah, you could talk of the flip side in terms of that people, the way that it's been framed for us is that the 15,000 that we're seeking to communicate with is people that aren't currently using drugs, that may have done it way back in the 70s, 80s, 90s, and the needle exchange isn't necessarily a relevant place to send them either. So it's sort of, it is a bit of it's kind of an interesting, it's a challenge.
But as you said during your talk though, it's the not, in a campaign like that dental ad, you've got 30 seconds, what are the bullet points and which is your target audience, and you broke that up. It's like there's the current people and then there's the people who don't know, and I think a campaign to work, it can't try and meet every single person, because then the message won't work, because it won't work for that group and it won't work for that group. So I think it's reasonable that this campaign is targeted to the people who've previously injected, and there are all the other things that Catherine is doing, that is going to be all the different health campaigns and different messages that it will be working with needle exchange for active drug users. But I think it's reasonable that this agency and this campaign keeps its message to its target group, because if the message is trying to cover 4 different target groups, then the message won't work.
Can I just add to that, just with the rheumatic fever campaigns, I've been involved with that since 2009, and we started out saying GP, but we definitely changed it GP, and it can be and/or health professional, because that GP is a barrier, and the health professionals just widens it up. That could be anybody, that could be a nurse, that could be so much broader. So I really think health professional, if we're not going to say that, I think GP and health professional, because loads of people don't have GPs, but health professionals could be a nurse, it could be a drop-in clinic, it could be something like that.
Cool, thank you. Well, thank you for that feedback. And we'll take that back on advice in terms of but that's really helpful feedback.
Darren, you don't get off the hook just yet. We've just got another question over there. Thanks, Sally.
Just a suggestion from me. We know that people with, hepatitis C, they tend to get stigmatized. If you're just targeting on that injecting drug, I don't think that's a good idea. Because people already feel being stigmatized, that a hepatitis C.
Is that microphone working? I can't hear her.
Yeah, so the question was just focusing on intravenous drugs as stigmatising, and just on that risk factor. So I think how I separate that, I think there's a few things in play. So at the end of the day, when you boil it down, 90% plus risk factor is through intravenous drug use. So we can't get away from the fact the success of whatever intervention happens, it needs to reach people that have done drugs in the past. How we do that is an interesting one, and that's why you'll see in the messaging we've wrapped quite a bit around how we destigmatise, and why we've included tattoos is not because it's a risk factor that has a high percentage rate for getting Hep C, because it gives people an out, and that's what came back from the research was give us an out. So we don't in the campaign list in a 30-second ad list all 7 risk factors, because you just can't fit them in, and at the end of the day, if one of them is 90+% of the reason, you need to go there. So we need to be overt, but at the same time we need to be careful, and I think the things that we've tried to do tactically around that is the 50,000, so it doesn't mean that you're isolated and it's just you're one of many. We've said if you've done it, even if you've done it once in the past. We've also said in the script there's many ways to get Hep C, and then we've even also said like tattooing, so you've got an out. So we've tried to find that fine line between getting the message, because that's really critical. This campaign needs to be successful. People need to hear that if I've done drugs ever in my life, I could have Hep C, and Hep C is a big deal. I need to get tested. So we need to achieve that, but it's just how we achieve that.
I think that's really good. Just echoing what other people have said. Other people have said about our GP or health professional.
Yeah.
And I agree with the foundation. If they're listing on their website the local people that they could go to, in various areas, then that would be helpful as well.
Yeah, that's good. So yes, we're going to be doing quite a bit on the website, that page, and so we need to make sure that the pathways on that page are quite clear and relevant for people. Thank you.
When you do campaigns like this, how do you decide on the probably had a bad enough voice. When you do campaigns like this, how do you decide on the time slots and stuff for the day, or how often that campaign goes on to get those target audiences, or to have the effect of people remembering that ad?
Yeah. We're fortunate with many things that they're very measurable, particularly like digital is really really measurable environment. So in this case, if we're going to be going on online TV, we know the target audience, they're all got ratings points behind them. So the TV stations that sell advertising know what programs, the demographics of the programs, because when you set up an account, you need to give out some of that information. So they know that, so we can choose the programs where we're more likely to get 45 to 60-year-old males, and then the time of day, you can get a gauge of that as well. So so we try to do placement to get as much effect as possible. You know, our hope is that our hope is that in the future we may have more funding to do more work in this space, but where we are with this is that we're trying to do as much as we can to use the money really wisely and make an impact and be where we need to be for those people. But it is a large audience. When we talk about 45 to 60-year-old and typically male skew, you're talking about 750,000 New Zealanders trying to reach the 15,000. So it's challenging, but it's a good opportunity. And there are some devices that we can use, like I won't get too technical, but you can do what's remarketing. So we're going to be advertising, and if people go to the website or if they watch the video, they can be what's called remarketed to. So if you've ever shopped at an online store and then you see those shoes appear in on your mobile phone on other websites when you're looking, that's called remarketing. We can do that on Facebook. So if people have shown an interest to find out more about Hep C, then within some parameters, because health is treated differently in Google and that sort of stuff, so we've got some restrictions, but we can remarket some more information to them to nudge them along the pathway.
Using big data.
Big data, yeah. That's a bit scary. Any other questions? That's to be confirmed, really. So we're working with the partners in terms of the launch date. So that's with the HEP Foundation and the Ministry. But we'll definitely be in touch with the wider community, stakeholder community, so that you're in the loop and it isn't launched and you're surprised and you go, oh, I didn't even know about that. Because we'll want to share all the assets that we have. We'll be wanting to share with you to be able to use through your channels as well.
Darren, thank you very much.
No worries. Thank you. Thank you very much.
So we are running a little bit ahead of time, which gives us various options. We could have an unscheduled team discussion, a workshop and ideas and brainstorming, or we could close up early and go down to a cafe on our way to the airport. We could go for a walk around the waterfront. So I think we'll just sort of open the floor for general discussion for a little while. I think there's a lot of expertise in the audience of people who bring different things. So on anything that we've covered in the last 2 days, has anyone got questions or comments or thoughts? Just, I've got no particular angle to lead here. Anything that people would like to sort of ask more about or get thoughts from their colleagues around the room? Are there many midwives here? 1, 2, 3. We're just raising the question about education for midwives around hepatitis B and C testing. So hepatitis B testing would be well into your remit now. I think one of our nurses is in the process of doing some pregnancy education stuff. You're working on something. So midwives is definitely a target audience of healthcare professionals that we want to be involved with education and things like that. So at some point we might be coming to your organisation with some targeted teaching around Hep B and Hep C. Hep C doesn't lend itself as well to perinatal healthcare because I think Ed touched on it earlier. There isn't, we can't treat while they're pregnant for a start. None of the DAAs have been clinical trialled in people who are pregnant. and also there isn't a specific intervention that is required that makes a big health outcome, like starting HIV treatment or starting hepatitis B treatment, where there is a definite goal and an indication for treatment and capturing those people. So, and also there's no vaccine that you can give the baby when it's born, so that there isn't as much to offer to the client at that window of opportunity. Yeah, I mean.
Sorry, it's me again. I was just a thought there that so often even GPs sometimes think that babies of Hep C mothers should be tested straight away after they're born, but really you need to wait until they're at least three for the antibody. For the mother's antibodies to be resolved in the baby. So I've often had patients ring me up and says, the doctor wants to do the test, and I say, well, no, not until they're at least 3. Somebody else got...
It depends on the status of the mother. Like, I think from what I've been reading, I don't need the
Yes, you do.
I think it depends on the status of the mother. So if, for instance, the mother has shown to have hepatitis antibodies, then you don't have to test until about 18 months. But if she's antigen positive, then you don't have to do it till 3 months. But then you would do yeah. C.
No. You don't test until they're at least anywhere between 18 months and 3, because they're still, if the mother is HCV RNA positive, then they still carry the mother's antibodies in their blood until about that age.
You can do it earlier.
It depends on what you're testing.
Yeah.
If you're testing for an antibody as a screen, you've got to wait till the mother's antibodies have gone. Whereas if you're testing RNA or antigen, you can test a lot sooner.
Yes,
that's the short. The other thing that's really important is, and Dr. Catherine Steedman says, is it's really important to test those children somewhere perhaps around the time they go to school, along with all their other testing, not to make a huge thing of it. But we've treated, and I don't know about the other secondary care nurses, but we've treated in the community people who are actually cirrhotic by the time they're 20, because mum had Hep C and they got Hep C from mum. So we've had about 3 that we've referred through to secondary care who are in their...
How old were they?
In their early 20s.
Yeah.
And in fact we had 1-year lad that was 12 and it was cirrhotic.
Yeah, they certainly do progress to cirrhosis much faster when they've acquired it vertically, with vertical transmission. Jenny, it's not something that we've put a lot of focus into, education in that field, so that's definitely something that we can put on our list to work on.
I was just thinking of this
Yeah.
more than anything else.
Yeah. No, it's good. It's a good topic point. Any other topics or ideas or questions that have come up into people's minds over the last day or so? We've got another roving microphone out at the back there, or if you want to speak.
Could I ask a question? Why do you not think they're going to look for a vaccine against hepatitis C?
It's not virologically possible. It's the scientists have been working on it as long as they've been working on the drugs. It's the virological science of the virus is such that it's so changeable that you just can't make. So it's the science behind it. I'm not a virologist.
No, but it is interesting. It's a cure for it. There's no vaccine.
Yeah, so it's the detailed science behind the study of the virus is such that it's very difficult to create a vaccine for Hep C. Chris, you might have something more intelligent to say.
Not on that particular point. I just thought one of the hepatitis B points that I didn't deal with yesterday, because I thought it was going to get dealt with in a subsequent talk, but never has been, was with the change in availability of tenofovir and entecavir for hepatitis B carriers. What are the criteria now for putting people on treatment? They have been in the past quite restrictive in that with the exception of cirrhotics, you've got to have had a high ALT and a high HBV DNA and proof of established liver scarring. That's been Pharmac's requirement. Pharmac's now out of the picture as far as selection of cases is concerned, and so it's going to be very much up to primary health to either make decisions about starting treatment or at very least to make decisions about when it's appropriate to refer to secondary care to consider starting treatment. And we will hopefully be putting something out from the Hepatitis Foundation very shortly about that. We're just trying to finalise. But to put it in a nutshell, basically anybody who has persistently raised, and I say persistently raised ALTs or intermittently raised ALTs over quite a period of months and years, with a high HBV DNA, particularly above 20,000 international units. But in fact, the recommendations are even more than 2,000 in the American criteria, should be considered for treatment. They won't all necessarily receive it, but they should be considered. So that's a much wider group than before and isn't dependent on established scarring.
So I think it is the ability for the prescribing for the hepatitis B drugs to move into the community, to your GPs and your practices in the sort of rural and remote areas. We're very happy that it's become more widespread and more available, but also the decision to start treatment is not necessarily a light decision, because it's not just 3 months yet we'll sort you out. It is a long-term treatment, and so we want to make sure that it's being started in the right way. So I'd encourage you, or if you know your GPs, are, to make contact with our admin staff and our nursing staff at the Foundation are very easily accessible on the end of the phone, and messages can be got to Chris and I to call back a GP to discuss a case. We're obviously not, Chris and I only work a small proportion of hours at the Foundation, but we certainly want to be accessible to GPs as they start moving into potentially into hepatitis B prescribing. Right, can we have a microphone up here? Kelly, this lady here.
Thank you. I'm just interested in those patients with hepatitis C who've managed to be cured, who haven't completely treated their course, or it's been a bit chaotic and they've started and stopped or whatever, and whether there's any anecdotal evidence as to what those factors are that would indicate more likelihood of being cured or not, whether their viral load was particularly high or lower to start with, or just around those sort of adherence issues.
And David might even be able to address this, the data, I think, from clinical trials and potentially even the real world Hep C treatment is that with the new direct-acting antivirals, there's a fair degree, we don't advertise this to a person when we're starting them on treatment, we want them to be 100% adherent through the 12-week course, but there is a degree of wiggle room. So if someone misses a week, and again, we don't say it's okay to miss a week, but we know that they'll probably still achieve cure. Dave, would you want to make a comment about that kind of the data that is in that field in terms of how much you can? Say all that again. So this is David from ADVIC, who's an expert for CureVac.
Yeah, we can get some data if you want to request it from our medical team, because it's kind of off-label, but there is a little bit of data to suggest if they take 80% of their Vicura pack, they should be okay, hopefully. Anything less than that, then they're hitting dangerous waters. So obviously the advice is to take as much of the medication as possible and try and be 100% compliant, but there is a little bit of leeway in that respect.
Any other questions at all?
I didn't have really a question, but I suppose the take-home message to the nurses that do an amazing job. You know, first of all, I want to say thank you, especially to my nurses that I work with in the different industries. But the take-home message for me is that we're all in this kind of together. Our focus is health and optimising people's health outcomes. And I think if we have the opportunities where we're doing full blood counts and doing things, and they're at risk over 25, you know, non-mouldy, and the different other risk factors of even HCV, that we tick those serologies, you know, because at the end of the day, it's only a blood test which is going to make the difference of someone's health outcomes in the future. So just taking those opportunities, given the statistics and the alarming rates of which, you know, hepatitis is growing, especially in our own country. That's the kind of take-home message. I hope that some of the nurses that I invited here today would take up in their different roles.
But do you have to get permission first to do that test, or can you just tick it yourself?
Well, I think that depends on which medical centre you're with or which place you are, because some people only like their doctors to have influence. Some people have told me that doctors are happy for their nurses to tick these things. A lot of places say health cost is also an issue with blood labs and stuff, and patients having to pay for some of these tests. But I've spoken to different labs around New Zealand, and what they said is if the person is at one of those risk factors, all you need to write is at risk on the form and there's no charge.
Sorry, and that's permission from the patient.
To have the test, obviously you'd say that, wouldn't you? You wouldn't just, you'd have to inform them. Yeah. And it's just a simple conversation by saying to them, you know, these are some of the risk factors for hepatitis, or you could even say liver issues. Would you like us to do some extra screening? We've got the blood now rather than coming back and getting another blood test. Just my thoughts anyway.
Jackie Elms? Jackie Elms just wanted to have a...
We've got a lot of resources left here, so please come along and take what you'd like. We've got some little posters that you can put in your GP practices or elsewhere, some blue ones and some orange ones. We've got lots and lots of holders with the Hepatitis Foundation cards, and then we've got lots of cards for all the individual nurses that work for the Hepatitis Foundation. We've also got some information about Hepatitis B, World Hepatitis Day, July the 28th, which is just around the corner. So some information there, some posters if you want to put them up on your walls. And please feel free to just take whatever you want. But you can't take my liver because I've only got one.
All right. Well, unless there's any other burning discussion points, I think we might wrap it up. What I'd like to say from listening to all these talks in this last couple of days, I'm first of all pleased that you've all come, and as I've said in my talk, I think nursing staff in the nursing profession in all capacities, prison, specialty, community, have so much to offer, and I think it's behoven on the clinicians, who are often seem to be historically the ones controlling how things are done, but in conjunction with Ministry of Health, with nursing leads, look at different models of care, doing things differently. So I know that there's currently lots of challenges, lots of barriers, but having you here is great to at least just raise the awareness, whet the appetite that there's health gains to be made in this area, and you guys can get job satisfaction from being involved with those. So thank you for coming. I hope that these talks have helped you to build your knowledge and to build your networks. I think everything we do, a lot of what we do is really, it's all about phone a friend, it's who your networks are. Have you got that good relationship with the other silos of healthcare providers in your physical region and in your specialty or in your flavour of medicine or practice around the country? So hopefully you've been able to build some networking as well. And in the words of two of our nurses yesterday, I think for me, I thought this was just a great wee quote. It's about the knowing and the telling, and I think nurses do that better than doctors. So I think if you can know the knowledge about the conditions, and if you can tell that to your clients in a way that they can hear it, then you're going to make so much of a difference. So hopefully the knowledge that you've learnt here, and hopefully you've been a bit inspired about what is happening with hepatitis B and C, and I urge you to go forth and to know and to tell. Thank you. One more plug. It's been a little bit mentioned, the Hepatitis C Summit, which is the day before World Hepatitis Day, is in Auckland. I think it's going to be a really productive meeting. David Clark, the Minister of Health, is going to be there, other Ministry of Health representatives, various government departments. I think it's going to be like the discussions we've had, but 100 times that, in terms of discussions around the room about what's happening and what could be happening and what should be happening for Hep C management in New Zealand. So I think if you're in any way interested and you'd like to sort of put your 2 cents worth in, or just hear what the discussions are about hepatitis C, please think about attending. The flyers for it are down that way somewhere, and there is support available for nursing health professionals to attend the conference, the day meeting in Auckland, so that if that shouldn't be a barrier in terms of help to attend. So if you're in any way interested in what's happening in Hep C in New Zealand, please come to this meeting. I think it's going to be a good day, and there might be some heated discussion, and that would be great too. Thank you. Is that it?